Welcome to today's Lunch and Learn. Today's event is titled Transforming Palliative Care and Rural Health, Building Blocks, Partnership with CCNY to Optimize Rural Health Integration of Palliative Medicine. I know we are probably all Zoom experts at this point, but I'd just like to reiterate a few housekeeping items. To help eliminate any background noise and to ensure that all attendees can hear the speaker clearly, please keep yourself on mute throughout the presentation. We do encourage you to turn on your videos, however, we understand if you're unable to do so. This Lunch and Learn program will be recorded and will be uploaded to CCN's website. At the end of the presentation, there will be a question and answer period. Please don't hesitate to place your questions in the chat box throughout the presentation or during the question and answer period. The chat box is located at the bottom of your screen. You're also welcome to utilize the raise your hand feature, which is located under reactions, also at the bottom of your screen. At this point in the program, I would like to invite Lauren Greco, Project Manager at CCN, who will introduce our speaker for today's program. Lauren?
Thanks so much, Alexa. Patricia Fogelman, Doctor of Nursing Practice, is the Assistant Medical Director of Palliative Medicine for Guthrie Clinics, a rural health system in northern Pennsylvania and the Southern Tier of New York State. Under Dr. Fogelman's leadership, the Palliative Care program has tripled the volume of palliative care consultations, helped to reduce patient length of stay, and demonstrated high rates of advanced directive completion. Dr. Fogelman was recruited to Guthrie after 12 years at Geisinger Health System, a not-for-profit rural health system in northern central Pennsylvania, where she worked in the division of pulmonary, critical care, and sleep medicine, along with palliative medicine. At Geisinger, she launched the nation's first pulmonary palliative clinic for advanced lung disease management and established a system-wide task force for advanced illness planning. Dr. Fogelman is the author of numerous articles and multiple chapters in the Oxford University Press's Palliative Care Nursing textbooks and a member of the National Faculty for the American Association of Colleges of Nursing's End-of-Life Nursing Education Consortium project, a national and international education initiative to improve palliative care, where she teaches the critical care, APRN, and oncology APRN tracks. Dr. Fogelman received her bachelor's degree at SUNY Geneseo, her BSN and MSN at Pace University, Pleasantville, New York campus, and her doctorate at Columbia University. She values working in collaborative systems, incorporating clinical innovation with advanced medical techniques, and is a passionate educator for advancing the care and support of patients of chronic and advanced clinical needs due to illness. Her successes at Guthrie include creating an enduring high visibility for palliative care with a formalized palliative care education for providers, nursing, and ancillary staff, community outreach, and most importantly, engaged partnerships with the hospitalist, critical care, emergency medicine, and oncology service lines to improve the care of the most vulnerable population of patients. Her clinical interests include EMR integration, palliative interventions for advanced lung disease, and bridging gaps in complex communications. Her personal interests include holistic healing, baking, boxer dogs, and amateur photography. So without further ado, it is my pleasure to introduce Dr. Fogelman.
Hi, everyone. Thank you, Lauren, for that really awesome introduction. Makes me sound a lot better than I think I might be. So hopefully it's not going to be too disappointing a lecture, but I am super excited to join everyone today and have a chance to kind of share with you our experience in not only building a rural health-based palliative care program, but also how a partnership with CCNY kind of helped us expand the reach of what we can do and the impact of the work we're doing. So I'm hoping that this will be helpful. So the first thing I always like to start off with is kind of what's the mission or the philosophy of the work we're doing. And I think that's really well encapsulated in this message from Dr. Ira Byock, who's really considered one of the icons in palliative care. And that's to say that if we in healthcare attend only to the physiologic without intending to, we are inadvertently abandoning people to figure out how to live through these difficult times of life by themselves. And so the premise of everything we do in palliative care is to really kind of say, how can we best support this individual through the various, courses and trajectories and ups and downs of an advancing illness or an already very severe advanced illness? And what are the mechanisms and therapies we can offer to provide them with improvement in quality of life? And so the very first step is to kind of say, well, what is palliative care? What is palliative medicine? The terms are interchangeable. I think you'll see them used pretty equivalently through, the marketing and the literature. So whether you're saying palliative medicine or palliative care, these are essentially the same thing. It's a multidisciplinary practice. I think this is what really most uniquely sets us apart from the other subspecialties of medicine. And that is our team is really comprised of multidisciplinary partners. So we, for example, on my team have a chaplain, a social worker, I have another nurse practitioner, as well as a physician who covers our Corning campus. And so we have this kind of fleshed out team. And then our greater team, kind of our system-wide work group, includes people from all of the realms of work we have impact with and on. So ICU members, pharmacy and therapeutics. We have membership from nursing and leadership on the executive level, as well as from our community partners. We're really focusing on providing patients with relief from their symptoms. So whatever the symptom is that they are experiencing from a progressive disease, is it shortness of breath from advancing COPD? Is it severe pain from a cancer? Is it profound nausea from advancing heart failure? Is it psychosis from your chemotherapy? Whatever the symptom might be, we're really here to help treat those symptoms, provide that kind of supportive management so that the quality of your life improves, so that the stress of the illness and what you're dealing with can be diminished, so that your overall sense of well-being improves, your satisfaction improves. And that translates into things just beyond the patient as well. Caregiver satisfaction and caregiver burden are also improved, with these types of interventions. It's appropriate for any age at any stage of an advanced illness. So I think that there's sometimes this really common misconception that it's only for the very old who are at the end of life, or only for the very, very sick, or maybe in the ICU, but truly any age we can treat. At Geisinger, where I was for 12 years before this, we were integrated across the system. And I saw patients, from neonatal ICU through the adult ICU. And towards the end of my career at Geisinger, we had branched into working with the high-risk MFM team as well to kind of be that supportive medicine presence through MFM high-risk term deliveries that we knew would end in a death upon delivery. So the spectrum and scope of the work we can do is fairly far-reaching, and we can treat these patients through their illness in partnership with the rest of their medical teams. When you talk a little bit about why do organizations need palliative care, the concentration of risk for really poor quality but high spending lies kind of within a relatively small subset of the population. And when you look at kind of the Medicare data and say, well, how are Medicare dollars being spent, you will see that the greatest utilization of Medicare benefits spent are often in the last 6 months of life. And that usually has not done anything to improve quality of life, extend their life, but was really high utilization of intensive therapies like ICUs and resources like that, but not without a significant improvement in quality of life or survival. So when you look at the palliative care data, you see that there's a ton of evidence that kind of supports that our efforts improve quality, patient satisfaction. We're also pretty cost efficient. And so there's a better utilization of the resources. And there's very few strategies that can kind of simultaneously do that. So improve care and quality, but decrease cost and utilization so that resources are being used more appropriately. That kind of on the hospital side, at least, for example, will translate into hospital dollars saved. So the graphic that I like to use is one of the ones from the Center to Advanced Palliative Care, or CAPC. And that kind of says what's some of the data that shows from the research we've done. You can see that palliative care consultation in advanced illness patients, 66% have a significant reduction in symptom burden and distress. So when you reduce someone's symptom burden, you increase their quality of life. And that translated out to 93% of those patients who received palliative care and felt the benefit felt that they were also going to recommend it to other patients, friends, or family who may be in need. So when you look at kind of how are we engaging in patients' care, how are we providing this care, it's really across a continuum. And once upon a time, this used to be, like a linear projection, so that as symptoms and disease worsened, then palliative care integration came up and kind of took over. But really what you see now is more and more, there are so many illnesses that people can be living with in a chronic long-term way. So think of your very severe COPD patients. They can live with very severe COPD for years. Doesn't mean they don't suffer from it, but they can live with it for years. Or our advanced cancer patients with the newer immune therapies and the oral chemo options, patients can live longer with cancer. It's no longer a disease that's just considered all or none. It's either curable or it's not curable. Cancer today is potentially controllable, which kind of brings it back under an umbrella of a chronic disease. So where we kind of like to intersect with folks is, along the course of your illness, you may have like times where your illness flares up and your symptoms come up and then you're really distressed. And so we may be more involved with you there, but then your symptoms come under control, you get to a baseline, you kind of hang out there, and then maybe we don't see you as often during those times. So we can kind of see you during these periods of escalation or de-escalation, as well as times of crisis. When you look at access, which is a huge issue nationally, 90% of hospitals who have 300 beds or more tend to have palliative care programs. And that's compared to about 55, 56% of hospitals that have fewer than 300 beds having palliative care programs. Those of us with the 300 plus bed capacity are 7 times more likely to have a palliative care program, and sole community provider hospitals tend to be a lot less likely. The one caveat that I will note to this is that smaller hospitals on the 300 bed side, for example, may have palliative care programs, but there is a broad variance somewhat nationally about what constitutes a palliative care program. So in smaller places, this might be like a nurse and a social worker, or it may be just a nurse, on their own, trying to deliver recommendations for palliative care. And so the scope and the breadth of the work that a palliative care team does in an organization can vary kind of very much depending on their team structure. So that is the one distinction I would make in terms of what access looks like across the board at different organizations. From an inpatient setting, just really keeping the focus on rural health for our talk today, we know that there's significant improvement in things like pain scores and symptom burden when patients have a concurrent palliative care consultation during an acute inpatient admission. So our very severe COPD or heart failure admissions, our ICU trauma admissions, our cancer complication related folks, these are all, very appropriate candidates to refer in for an inpatient urgent, relatively urgent palliative care consultation. When you kind of divide that up further down and say, okay, let's look at some of these high-risk groups. Heart failure is probably the #1 readmission diagnosis under the 30-day readmission criteria for most organizations. Certainly it is. Here for us, it was the same way for us at Geisinger. So when you look at heart failure patients in palliative care consultation, you see that these scores are improving significantly with utilization of palliative care. And the symptom burden group had a significantly higher level of patient satisfaction and well-being than those who did not receive palliative care consultation. You also kind of look and see the folks that we're seeing in consultation often have a lower 30-day readmission. And that's really because a lot of times what we're doing in the context of these admissions is not just managing their symptoms and improving that symptom burden they suffer from, but it's also really addressing the overarching goals of care and advanced care planning conversations. So why do you keep coming back to the hospital, for example? Well, I'm running out of oxygen, or I don't have help for XYZ. So if we get them connected to home health, for example, then you have some more oversight. You have people who are coming into the house to routinely check on this patient. You have someone who can assist this patient with medication management. I have a patient right now in the hospital whose reason for readmission is that after his discharge not too long ago, he represented to the emergency room seeking a refill of his Keppra for a seizure disorder because he didn't know that he was supposed to go to a primary care office. In fact, I don't think he even realized he had an appointment scheduled. And so he represented to the hospital and then coincidentally was found to have some other issues that required a longer term admission, so he's being followed now for that as well. But these are folks that if we had them on like a good home health regimen where there's a visiting nurse coming in a couple of days a week, home health aid support, medication management going on, then there's someone kind of there to help navigate this patient through these like really difficult times. And again, that kind of goes back to what Dr. Bayok teaches us, right? That if we just pay attention to only the physiologic issues, we very much are leaving people on their own to figure out how to get through these really difficult times. And for us, the technical lingo, the processes, the resources, this is all very natural language to us because this is our industry. But is it really natural to anyone else who's not in this field? I mean, it's like sticking me in the car dealership shop and saying, we're going to sell you this car that's got XYZ, benefits. And I'm just going to be like, all right, does it get me from point A to point B? I mean, I don't know anything about automobiles. Like I have zero interest in it. I'm not probably the best person for you to talk at in that much detail about those things. So it's that same kind of, translatable concept. Like, are we doing as much as we can to make sure people are supported through these like really difficult times? Dr. Castle, who does a lot of really awesome palliative care research, also noted that when you see patients, in hospitals across the board and look at the ones who had palliative care consults versus the ones who didn't and kind of stratify and match them for age and diagnosis, those who had consultations generally had reduced readmission compared to the ones who did not. So Institute of Medicine has come up with some significant recommendations, advocating for the utilization of better palliative care integration, as have other professional organizations like the American Thoracic Society, the American College of Chest Physicians, the American Society of Clinical Oncologists. And so IOM findings were probably kind of the biggest driver of recent changes that tells us people who are nearing the end of their life are not physically, mentally, or cognitively able to make decisions about care. So these conversations about what preferences would be, what their desires are, what their need for resources should look like, need to happen sooner than when they're just nearing this end of life process. When people have that opportunity to indicate an end of life care preference, most of them will tell you that they want care that's focused on alleviating their pain and suffering. They want to be at home or with their families, but they certainly don't want to be here in the hospital or in a nursing home or in an isolated setting. Frequent conversations between clinicians, providers, caregivers, and the patients are really necessary to kind of make sure that along this trajectory course of illness, we're re-engaging, revisiting, and updating the changes they may have. So you might have wanted to be a full code 5 years ago when your COPD was diagnosed, but now fast forward, 5 years later, your FEV1 is dropping, you're on significant amount of oxygen, your performance status is lower, that your chances of coming off a ventilator are significantly lower than they were 5 years ago. Do you still want to be a full code under these circumstances? And so those conversations have to be ongoing. They're not a static conversation. It's a very dynamic, ongoing conversation. Some of the findings we know is that public education and engagement is really important. There's a host of national organizations and national initiatives and different kind of grassroots projects that are all underway to kind of help improve some of this on a public knowledge level. So certainly the Center to Advance Palliative Care, or CAPC, is one great organization that does this. There's Endwell, which is an organization that focuses very much on kind of the end of life processes and being able to advocate for people who are in an end of life or helping to plan for a healthy, and when I say healthy end of life, I just mean like an end of life process that's according to what you want it to be, and not a haphazard, chaotic, or unplanned process. Most Americans, though, really lack knowledge about end of life choices. That is not helped by how media portrays things. Certainly we have a sense in this country that's very false of what critical illness and dying are like. We need to first start by normalizing a conversation about death and dying. So groups like Death Over Dinner, for example, lead initiatives to kind of encourage families and communities to sit down with their older adults or their loved ones and kind of have a very normal, reasonable conversation about some goals of care and some advanced illness planning over the context of like a family dinner. So like, you know, what are you going to talk about when you're gathered together as a family? We're going to talk about some important issues. And so it's not meant to be, again, like a one and done conversation. It's meant to kind of be the opening the door to here are some things we've all been wondering about, and then keep the dialogue going. So when you look at the other side of things, you know, not just is there a need for education on a national level, you know, from the public consumer forward facing perspective, there's also a very real concern about the provider availability in palliative care. And so Dr. Kamal, who is a researcher, a medical oncologist and palliative care physician at Duke, does a lot of research in palliative care, and a 2019 study that he did revealed that there's going to be an increasing shortage of palliative care clinicians, you know, in the upcoming 10 to 15 year range. And that's because when you look at kind of who's out there doing the work, 2 out of the 5 of us are over 56 years old. And so pretty reasonable to think that in the next 10-year window, we're probably going to be heading into, or if not already heading in retirement. It's super important to remember there's more than 10,000 Americans who turn 65 every day and become eligible for Medicare. And again, older adults have more chronic problems that are more progressive and then become more appropriate for palliative care innovation. There is going to be what we're calling an impending workforce valley. So the combination of an aging workforce, retirements, and then burnout, all kind of contributing to this deficit and this paucity of shortage on providers that we're going to be experiencing. And if you look at what the trend slices out to be for that, by 2045 is when we might recover from the shortage if we don't have some changes now that need to kind of start at the policy level. So there's, you know, some legislation underway right now with the Palliative Care and Hospice Education and Training Act, which is making its way through legislation at this time that really helps kind of provide a structure and a process to improve funding and support for palliative medicine training fellowships, to incentivize organizations to provide those types of supportive measures, to provide better implementation for billing and reimbursement and compensation. So, you know, everyone who comes into medicine has a right to kind of choose a field, not just that they enjoy and that they love, but also that they can make a reasonable living from. And sometimes when you look at what are the compensation metrics for different subspecialties, some of them certainly pay less than others. And so you find a lot of times that people are just unwilling to go into these arenas that don't have as good a compensation ratio. So that kind of like helps us shift our focus into what are we doing here at Guthrie, and what were the founding principles of building a palliative care program here. And I started off with kind of wanting to make sure that we all remember that fundamentally illness is personal, and seriously ill patients and families are facing a serious crisis. I'm seeing patients in the hospital who are among the sickest and the most vulnerable of the patients that we treat. So a lot of times I think we focus really hard on the physiologic, we treat the disease, but we're not remembering that there's whole people there. There's families and caregivers, and that person in the bed is also a whole person that has to be thought of on a more comprehensive scale. So our goal in palliative here is to make sure that our care that we give you is not just medically excellent, but honors your inherent human dignity, and then takes that one step further and says, what about the world around you? What are the additional things that we need to be concerned with and providing some support and intervention for, so that you have the most optimized scenario to return home to? I think that the need for a diagnosis and treatment is always important. Helping them kind of sort through what that could be is important, but it's also really important to help people die in a way that feels right to them and their families. Families ultimately want to see that we as medical providers, we as community caregivers, are honoring and celebrating the lives of the people they love, that we are acknowledging their personhood. And I think that our practice has to shift a little bit more back to kind of the humanity in medicine versus the technicalities that we've kind of become far too proficient in. So what are advanced illness patients asking? Kind of simple things, right? Know me, care for me, ease my way. Those are the three things they're fundamentally asking for. So when you take that step back and say, hey, they want you to know them, care for them, ease their way. First start with, this is fundamentally a whole person that I'm going to take care of. They have a need for all these things that are on the screen: physical comfort, emotional well-being, interpersonal well-being, spiritual well-being. And why is spiritual well-being important? Because not all suffering is physical, right? Someone could be sitting in their bed crying, looking very distressed, telling you they're in tremendous pain. Maybe you gave them some pain medicine, but it's not helping. That is often a really great sign that the distress that they're feeling is an existential or a spiritual distress. How can we better help support these folks? What are the members of a multidisciplinary team that can help provide that support? So for us, we're lucky. We can call a chaplain, we can integrate with a social worker. We have multiple people that we can kind of bring into the fold to help us, again, take care of this whole person in the bed. So we're trying to give you care that's not just medically excellent, but really melding it with some tenderness. And so the whole organizing principle that I kind of come back to is every person's a whole person. Fundamental nature of illness and dying is personal. So you have to remember that when you're not just taking care of the patient, but also the caregiver. Quality of care requires that the treatment we give is consistent with the values, the priorities, and the preferences of the people we are caring for. That is what is often referred to in the catchphrase goal concordant care. How do you figure out what goal concordant care is? You have to talk to people first. You have to sit down, you have to ask them what matters. You have to figure it out over time. You won't get it done in one 20-minute conversation. It might take 2, it might take 3, but you have to figure it out in discussion and conversation because, again, these are actual live human beings and they are whole people. The last thing, and this is probably the most important bit of it, and this is what we really try to make an impact here at Guthrie because so many of these patients are so critically sick. And if nothing else, COVID has taught me in the last 18 months that principle number 4 is really where I needed to spend more time and attention. Sovereignty over illness and dying belongs with patients and their families and their communities. It does not belong to me in a hospital. It does not belong to a facility or a healthcare organization. It belongs to patients, their families, and their communities. How do we do better to make that possible? And so a lot of our work is to kind of sit with these patients, to talk to them and their families and say, what would make the most impact for you now? What would bring the most quality to your life now? How can we support that? And what do you need to be able to support that? And sometimes you can send them home with hospice because they have adequate family support. Sometimes you can't because they might not have adequate support or they don't have a safe home to go to. And so what is then the next best option? Is there a hospice home that I could try to get you into? Is there a nursing home close to home where you get the technical care you need, but your family can come in and still be that whole person support that you need? What are the ways that we can try to kind of figure this out for you? And that kind of brings you right back to illness is personal. People are in times of crisis. This is an incredibly personal time for them. And we have to remember that the care we bring, regardless of the degree or the extent of our technical sophistication and all our machinery and all our high-tech integration, doesn't really matter as much as the humanity that we bring with the caring we give. The quality of the care we deliver requires treatment that's provided is consistent with what patients are telling us they want. That sovereignty we've discussed is important. When you can't make this happen in homes or communities, try to recreate that sense of home and community in the setting they're in. Is there a blanket or a pillow or some music you could play? What do you need to do to bring that in? So this part we've kind of gone over, and so I don't want to hash that out again, but when patients are telling us to hear them, what they really want to say is they want to live as full as they can until they die. That tyranny, that tick, tick, tick that I think a lot of us sometimes are aware of from time to time, or some of us live with because we have a chronic disease that we know might be cutting short our time, affects all of us differently, but we're all on some level aware of it. Storytelling and listening are proven methods to help preserve that value and that sense of humanity for patients. It's a key to caring for them. A lot of times in some of my family meetings, I'm commonly known for asking people, especially if there's long-term spouses, how did you guys first meet? What's your story? Because the person in the bed, like on the chart, I know that part. I've come into the room prepared with the medical stuff. What I want to know is like, who are you as a person? And let me hear more about your story, because that's going to help me shape a plan that's probably going to be a little bit more tailored and appropriate for you. And so our initiatives, I think, were pretty straightforward. We want to continue to provide care that takes them through advanced illness to hospice when appropriate. We want to make sure that we're continuing to provide them with care through all of these times of their life. I think that some of the stuff we're telling you shows you guys that we're going the distance to kind of make an impact for these folks. We're really looking to reduce human suffering. So when you live well, you hope to die well. How do you do that? First, you got to increase the dialogue around what's the best care at the end of life. So this is a national imperative, at least on the perspective of a palliative care provider. It is. Only 1 in 4 patients, or Americans really, are speaking with a loved one about their wishes. So take an internal poll, like, are you one of the 4 that have spoken with your loved ones about what your wishes are? Have you ever broached that topic with an aging relative or family member or parent, for example? There are worse things than having a loved one die, as Dr. Bayek has often said, and that's really having a loved one die badly. And so that's why these conversations are important. And so when I took over palliative here, one of the first things I had a tough lesson to learn was the resources are different in smaller rural systems. And so at Geisinger, I had a child life system and I had child life workers to kind of be able to call on and partner with. And so even if I had a patient with children, so the child was not the patient, the child life team would still help me because my patient had children. And one thing I very quickly learned here is that here we are taking care of patients who have young children or children of varying ages in their families, and we have no support for them at all. And in all of the teaching that I have done and all of the literature that is out there, that children of sick or seriously ill patients or siblings of very seriously ill patients are often the ones that are they're neglected and the ones that are kind of lost in the process. So my wish was kind of like, how do I do better to meet that need? And so, a lot of you probably know, I hope, Josie Robles, who was our Care Compass New York District Coordinator here at Guthrie, who's recently retired, and I'm incredibly envious of that fact for her. But Josie kind of came to me one day and said, we have the opportunity to get some grant support through Care Compass. And it's, really kind of built on, you have to meet certain metrics of delivering palliative care, so provide the supportive documentation. And for each metric and level of documentation that you provide, there's some additional funding that's provided. So we took that under advisement. We started looking at our data. We started submitting, for the different metrics to make sure we're providing the justifications that was needed. We looked at our internal cell program and said, what are the things we need? And again, what I kept coming back to was the fact that there are just this unmet need of the children that we're caring for. And so how do you build resources? And the very first step was to say, okay, we've gotten this funding. It was very generous funding. How am I going to build some resources? I started with pediatrics. Why does that matter in rural health? Because there are grandchildren being raised by their grandparents in this community, in this large rural, low population density, but widely spread out. And there's a population just with higher comorbidities, higher risk of death, younger patients with really advanced diseases, whether that's cancer or other multi-organ system failures. So what I have listed for you in the italicized font are some of the titles that we've been able to obtain with our grant funding from CCNY. And, you know, my purpose in researching all of these was to make sure that we had something for every age. It is not fair to just say, you know, I have a couple of books for toddler age people, or I have something for school age kids, but there's teenagers and there's late age teenagers or very young adults all going through different levels of angst, but like nobody's helping them. And so we had to do better. And so everything you see on this list, I've personally read the book because I had to make sure that it was going to be appropriate. Some I had prior experience with, some were new to me. And then I'm lucky enough to have friends, you know, with children of various ages. So I can kind of dole out a book here and there, be like, hey, read this and tell me what you think of it. So one of the first ones we got were, and we've gotten like 50 to 100 copies of each of these. And so wherever you go, my love will find you, is more for younger children, like 2, 3 years old. And it's like a little thick cardboard flip book that kind of talks about, you know, when you lose someone important to you, like a parent, that love they have for you and the love you feel for them carries with you through life. So it kind of helps them see through these different graphic illustrations that that love never leaves them. So when we had that happen here in our oncology floor, we had super young guy with like a 3-year-old, excuse me, dying. And our entire oncology team signed the book for his child. So these are the kinds of things that you guys helped make possible for us. We have Freddie the Leaf, which is kind of how, you know, the cycle of loss and how people, you know, live through grief. Echo's Sister is more for like preteens, really good reading in that regard. Cinnamon Roll Sunday is another good book for young children. We did some stuff for teenagers. So Feeling Better, the cognitive behavioral therapy workbook for teens, because teenagers don't really want you to like read to them. They kind of want you to let them do some stuff on their own. So we got some self-directed type things. We have The Invisible String. We have Caleb and Kit, which is also fantastic for like that preteen to early teen population. The Blue Day book is really good for your like 6, 7, 8-year-old population, because it kind of talked about what sadness is about and how you can deal with it and how it's okay to have a blue day, but to remember the good things. And then The Jester Who Lost His Jingle is a book that I've been using forever that we were able to get as well. So then we kind of said, okay, we've built this great pediatric resource library. What more can we do? And then we said, well, we have adults who also have needs. And, you know, we need some more stuff for dementia support, for caregiver support, for legacy work, for our cancer patients. You know, what more can we do? So then we took some more funding and we built an adult palliative resource library. And so we have a variety of things. There's a hilarious book. Can we talk about something more pleasant? This is a Pulitzer Prize winning author who wrote this book kind of about these conversations that she was trying to have with her aging parents and how they were just constantly like, can't you talk about something more pleasant? Why do you keep bringing this up, this death stuff up? And so it's kind of this narrative, but illustrated, kind of follow along with me through that process. The Lighten Up book is really good, especially for like stress and coping. It's just like almost like a daily affirmation type of thing. How do we tell the children? So if someone that you're caring for has a really advanced illness and they don't know how to break the news to their children, or they don't have the words, like this is a book you can give them. And again, all of these, I have anywhere from 50 to 100 copies of each of these. How to help the children through a parent's serious illness. And then we get into some of our, you know, our dementia books. The Reluctant Caregiver and Grief Day by Day kind of helps our dementia caregivers work through the process of grief and loss, sometimes as the person's dementia is worsening, sometimes after the dementia patient has died, and just kind of getting used to a world without them in it. How to Be Sick is a great book, kind of written from like a Buddhist perspective about how to deal with chronic illness. A Caregiver's 12-week journal is very, very good for like the post-acute loss bereavement period. It kind of gives people a focused activity to kind of work on through those first couple of months of grief and bereavement. And then for patients who have a dementia that's progressing, but maybe have a little time, we got copies of Our Story, a memory book, where they can build, you know, a legacy review into this book. And so you can say, here are some of my favorite memories. Here are some photos of some of my favorite events. Here were, things I really enjoy doing or some of my favorite recipes. And it's something that you can carry on and pass forward, and leave behind for families. And then I said, okay, we've done great. We have adults, we have pediatrics. We should probably also look to see what can we do to support our providers and our staff. What can I do for my residents, for my nurses, for my other fellow colleague providers that I'm working alongside. So we kind of said, okay, well, here are all the places we teach: resident and nursing education. We do grand rounds, provider education by department. We do care coordination, care management lectures. So we're like, okay, let's find some materials that are appropriate now for this population. So That Good Night is a fantastic book written by a physician who was facing critical illness and kind of what happened to her through that process. Demystifying opioid conversions. This is probably like my greatest accomplishment. This book is written by Marilyn McPherson, who's a pharmacist at the University of Maryland, who is known internationally as one of like the defining leaders and educators in opioid safety and opioid management. And that book is a pricey little book, but we have 100 copies, and we are educating our residents, and we are able to give these books out, and we are generating an era of residents who are safely and appropriately using opioids, prescribing properly. We have copies of the book in appropriate places, an oncology clinic, family medicine clinic, in the pharmacy, ICU pharmacy, et cetera. So people have reference materials. They can properly kind of review things quickly and make sure, are we converting the opioid properly? Are we doing good drug selection? Because really, when I first got here, if you looked at opioid orders here, like instead of like trying to titrate a drug, you would see people ordering, morphine 2 milligrams IV plus oxy-IR 5 milligrams plus tramadol plus dilaudid IV. And I would be like, so why do we have a buffet of opioids for a patient instead of like pick one drug, titrate it up? Well, I didn't want to go too high on the dose is really the answer I got, like 9 times out of 10. And I was like, yeah, but putting 3 other drugs in there doesn't actually help, because you're just confounding the picture. If they have a reaction, nobody knows what they're reacting to. So it's gone a long way to kind of help improve our safety and our understanding, and kind of help demystify these myths that people walk around, with opioid management. You can't just walk around saying opioids are bad. That's really not an answer. Opioids are bad if they're misused, but you as a provider have a moral, ethical, and legal obligation to use them safely and order them wisely. So learn how to do it. It won't be so intimidating. Best Care Possible, and then a book by Ira Byock. If anybody on your team wants one, if you guys shoot me an email, I will happily put one in the mail to you. I have plenty of copies of that. Tuesdays with Maury, we have a gratitude journal that, I felt was important. We have some residents who, kind of getting overwhelmed with the COVID work and starting to burn out and trying to figure out, like, why did I come into medicine? And you're seeing a lot of blog posts and stuff like Kevin MD and stuff like that, where people are questioning why they came into medicine. So this was to kind of help people refocus on, why they came into this field and what were the important things that matter to them to make a difference about. Blue Nights, which is Joan Didion, who is a phenomenal author. And The Year of Magical Thinking is actually her book as well. And that's probably one of the most formative readings I've ever had. And Joan Didion's Year of Magical Thinking is really about her sudden unexpected loss of her husband, with a traumatic coronary event. And just kind of how that first year was just very, not the expected stuff, and how she just kept thinking about, well, if John was here, this is how we could do it, or we'll do it this way because John would like it this way. But it's really magical thinking. John's not there anymore. And so just how she processed through these steps of grief is really helpful, I think, for many to relate to. So my takeaways before we get to some Q&A: people are at their most vulnerable when they are ill. And so we really need to remember to approach the care of these folks with compassion and kindness. Meld the best of your medical diagnoses and interventions, but bring your caring and compassion to each interaction. Encourage your community involvement and support. Encourage the families to be involved. There's no reason with the technology we have today that we can't have families more involved in conversations. When family members tell me, well, I live 3 hours away, I can't get there, I'm like, great, if you have a cell phone, we'll do a Zoom. And, I have a lot less compunction about texting people a Zoom link. I know sometimes they're like, well, I don't want to have to text it because then they'll have my cell phone number. I'm like, I know, but I guess you can just take that chance. Like, what are the chances someone's going to call you incessantly? Pretty slim in my experience. So I'll text you the link. And I do this intentionally because we have a palliative medicine Zoom account. And then I literally just say, click this link at 12 o'clock to join the meeting. And that's all they need to do. And their phone just figures out the rest. Welcome their participation. And that's how you do it. Make the platforms you have accessible to people so they can be part of the conversations. Temper your words and your actions with love. And as Dr. Bayek says, when people are nearing the end of their life, there's oftentimes just really 4 themes running through that people just need to kind of have said to them or need to say. And these are the things that matter most. So what you see on the screen is really what people want to hear or say when they're at that stage. Please forgive me. I forgive you. I love you. Thank you. Very simple, straightforward things. In his book, The 4 Things That Matter Most, kind of go more into detail about that as well, which is another reading that you can consider. So, I always kind of end on, what are we really here to do? And so my promise to the patients that I care for and what I try to do every day, I come in here every day with this intention to reduce human suffering. And how I do that is variable day to day. Maybe one day I make your shortness of breath better. Maybe for someone else, I might have improved their cancer pain. And maybe for someone else, I just put all this stuff on the table and we had a really honest conversation about how sick they are. And so they can make some decisions. So be unabashedly tender with the people that you serve. So kind of the last slide here, if you want to learn more about palliative care, I've listed a bunch of things, a bunch of resources here. You can go to the CAPC website, which is getpalliativecare.org. There's several really good Apple podcasts. I just listed 3 of my favorites up on the screen. So Jerry Powell just this past week had a great podcast on behavioral economics. When is a nudge a shove and when is a shove a nudge, and talking about compassionate and critical illness conversations. And then suggested readings, a lot of these books we've talked about. Catherine Mannix's book, Listen, just came out. Tricky thing I'm trying to get this book, and it's just being sold in the UK right now. And so I've been super reluctant to buy it from a UK bookseller because I didn't want to pay for international shipping fees just yet. So I'm waiting to see if it'll come out on like a Kindle version so I can just download the electronic version. The How to Be Sick is Tony Bernhard. I have that book at home. That is a great read. It is not real intense or upsetting. It's a very gentle, fluidly written read. You can read it in bits and pieces. And then Joan Didion's The Year of Magical Thinking, as we discussed, is also another great read. So I'm happy to end here. I have references here for you guys if you're curious where some of my information came from. But I'm happy to take any questions and anything else if I can help. I don't know how to get out of this screen now, but I'm trying to get to your chat screen. Here we go.
I was just going to say, at this point, there are a few comments in the chat box, not necessarily questions, but can you see it, or would you like me to read them aloud?
Yeah. So
okay.
Child life specialists and community health workers thank us for our whole person-centered simple language approach. Yeah, I think that I'm with you 100%. That's really how you have to approach people today. So there's another recommendation from Ashley. It's Okay That You're Not Okay by Megan Devine. So I think we may look into that. That's another good suggestion. So thank you. The Good Grief program at Boston. Yeah, I've heard of that. Our social worker actually is the volunteer director for the Camp Good Grief here, which is a volunteer run annual grief camp that hasn't unfortunately happened in the last 2 years because of COVID, but happens every summer otherwise. And she kind of helps lead those efforts. And will we receive a copy of this presentation? I think it's being recorded, right, Melissa? I think.
Yes, it's being recorded.
Yeah. Yeah, all good comments. I'm happy though to take any questions if anyone wants to unmute themselves or type it in the chat box, I guess. It's a lot of information, so it could be a little overwhelming.
Dr. Fogelman, this is Lauren. Thank you so much for all of the outstanding work that you've done. And I know I've said that probably ad nauseum at this point, but I really just love, and just hearing it in the context of this, and all that you've done for children, and just, taking all of that into consideration, it really just, it gets right to the heart of everything that we do, right? I did want to ask you, and in my experience within the implementation of palliative care throughout different organizations, there can be a lot of different challenges just as you look, as cultural shifts, or really having the conversation, throughout, the different departments of physicians, whether that be cardiology or oncology. Did you have any challenges like within the context of implementation? If so, how were you able to handle that?
Yeah, so that's like a loaded question, right? So there's always challenges. I will tell you, we had very little problem with oncology here, but the reason is that palliative medicine here is part of the cancer service line. So, there's the cancer service line is made up of chairmen that are radiation oncology, palliative medicine, and medical oncology. I lead palliative. Phil Lowry leads MedOnc, and then Omar Yuman has just stepped down from radiation oncology, and Tom Gergel has taken over. And then Phil Lowry is actually chairman of cancer service lines. So, it's really easy to integrate into oncology when you're chairman, you're part of the service line. What's been more of a struggle has been trying to kind of get through the resistance of individual members of the cancer team who just may view palliative as hospice and really can't see beyond that. And so I think the key to this is really ongoing education and in-services and conversation. ICU buy-in sometimes takes a little bit of time. We had to kind of prove that we were useful, but the chairman at the time also felt that there was value to palliative care. So I tended to start off when I first got here by meeting with all of the key stakeholders. So I had one-on-one meetings with the chairman of home critical care, with cardiology, with internal medicine hospitalists, to kind of talk a little bit about how can we better help you guys? Where are your needs? How do we better improve the care we're giving patients? And the example I'll give is, before I came here, there had been like some type of a quality project with the residents a year or two previous. And somehow that just resulted in this automatic palliative care consult for any patient admitted with a diagnosis of heart failure, which, as you can imagine, is the #1 readmission diagnosis, is an absolutely ludicrous volume of heart failure consultations on people that we might be seeing repeatedly in 30 days. And so when I saw this, I was like, why do we have 8 new heart failure consults today? And, my team was like, oh, well, I think there's like an automatic trigger. Were you involved in that? No. Well, how did you build a trigger for an automatic palliative care consultation without actually having involved the palliative care team in the process of developing said trigger? So then I had to go backtracking and dig through it. And, when I finally like reached the source, and I was like, so where's your data? Like, what did you guys use? Like, what were the studies you looked at? Not a single palliative care and heart failure study had been utilized. So they had no triggers. And I was like, okay, so time to revamp this. Until you fix this, I will decline every automatic heart failure consult. And you need to fix this because there are identified national triggers for when palliative care in heart failure is an appropriate consultation. You need to better utilize the national triggers. And I met with the cardiology chairman who was like, yeah, let's work on fixing this. And so, that had to get fixed because honestly, it's a team of 2 people here. There's myself and Wanda Foote, who's the other nurse practitioner. I have a 3rd nurse practitioner starting in November, but she is a brand new, fresh out of school nurse practitioner. Really good ICU experience, but no nurse practitioner experience, no palliative experience. So she's on a 6-month trajectory, for onboarding and orientation. So it's still a small team. We have a team of 2 providers. We're seeing 1,200 new consults every fiscal year, which is a volume that supports a staffing of 5 providers. So let that sink in for a minute, that 2 people are doing the work of 5 at this organization. And we don't have other support. We don't have a designated secretary. We don't have designated additional services. So we kind of have a social worker, we have our chaplain to rely on, we have our hospice nurse liaison, and then we're pretty much, kind of doing it. And so I think that, sometimes out of necessity, we kind of have to say, well, let's go to the low hanging fruit. I built an acuity trigger, again, with Josie Robles, using some of the things like the frailty score, the LACE score, the readmission stuff, and then looking at different triggers that are identifiers for an inpatient acute palliative care consultation. So every morning I get an acuity report, and there's 9 triggers that we identified. And so if patient score 6 or higher, I review the charts, and then I'll reach out to, the primary team attending if I think a consultation is warranted. The good news is that we've been tracking how good that trigger is at capturing things, and we're probably seeing about 45% now of the patients who are scoring 6 or higher. When I started and we were still refining it, like 85% of the patients we saw were scoring like 2 and 3, so not quite the acuity we want to be seeing. And so we had to kind of start refining that a little bit. So I think there's all different ways of doing it, but I think the very first step is engage your stakeholders and have some conversations and kind of see where you can help them. And then, I had a boss at Columbia, my old chairman at Columbia in New York, who would just say, sometimes you just got to keep your head down and do your work. And then your work speaks for itself. And I think that's also been the case for us in the last 2 years with some service lines. Trauma has certainly come to see our value, but that's really just been from keeping our head down and getting the work done. And so now they're kind of like, oh yeah, let's get palliative involved a lot more earlier. And so we're getting there. Baby steps all the time, but there's progress.
There are a few other questions in the chat box. Do you encourage all providers to have goals of care conversations in the hospital, or do you usually have them triage palliative care? What are your thoughts on the correct times to triage palliative care into the hospital?
So, everyone should be a good primary palliative care provider. That should just be part of routine good care. So a straightforward goals of care conversation, I do not think warrants an inpatient palliative care consultation, which is really something we try to utilize for higher acuity type of visits. So to be very, very straightforward and totally transparent with you guys, like when my census is lower, so pre-COVID, there would be periods through the year where our census was more manageable, like 12 patients on the list or 14 on the list. And if that was the case and 1 or 2 new consults came in that just said goals of care, we would see them because we had this manageable volume. Now in this era of COVID, our average daily census is 20 to 26 on any given day. Under those conditions, because we have to triage for the higher acuity, so ICU, COVID ICU, main floor ICU, and then COVID units, so COVID med surge, COVID step down, have to be where the priority shunts to, because the higher acuity and higher needs of the patients are there. And so in these times right now, we are triaging a little bit more for non-essential. And the example I'll give is I had a patient consult come in the other day who was a patient with some heart failure, but they had his discharge orders ready. I mean, he's dressed in his regular clothes. His wife is here with the keys in her hand to go home. And they're like, oh, we put in this palliative medicine consultation. Can you come see him to address code status and goals of care? I'm like, what, in 15 minutes? Like, I can't do that. I mean, I'm good, but I can't do that in 15 minutes. Like, are you nuts? And so I was like, no, you're sending this patient home. They can come see me as an outpatient. That's not urgent. And then the objection was, oh, but they're already here. It's like, well, then you had 7 days to think about this before 15 minutes before you're going to discharge him. And so sometimes I think there's that little bit of, we've gotten a lot more effective as a team of looking at the referrals and scrutinizing them and kind of combing through the chart to really see what the needs are. Sometimes you'll get a referral and it'll say goals of care, this, that, and the other thing. But when you look in the chart, no one has addressed anything. And so then sometimes you got to push back and say, well, you guys need to try to have an initial conversation if it's just about goals of care. If there aren't other high acuity needs, I'm not sure it's a fair utilization of my team's time. Can you get the PowerPoint as well? Yeah, I can, or I can send you the links if you tell me which ones you want. In the outpatient setting, how do you help patients understand when to call their PCP, cardiologist, or pulmonologist versus their palliative provider? So I tell my patients, the ones that I follow in clinic, if your question is about anything that I'm managing for you, feel free to call me at any time. If you feel that your disease is changing somehow, or what you're experiencing as a result of your disease is becoming more problematic, more intense, or worsening somehow, feel free to call me. If you're just comfortable calling me first so that I can tell you, I don't think this is something I should handle and you should call so-and-so next, that's also fine. I think that sometimes you got to give people a little bit of an out, and kind of help them with some guidance. If it's straightforward stuff, like if you want to refill on your Lipitor, you need to call your primary. If you want to talk about your upcoming cardiac cath, you should call your cardiologist. So try to kind of identify, the proper call to the proper provider for what your question actually is.